Thank you, Dr. Meher Zavin, and thank you, audience. After 2 days of exhaustion, so many lectures from 50 plus faculties from abroad as well as from home country. I'm taking only 10 minutes from you with my presentation. So already Dr. Meher Javin introduced me. So before starting with my talk, I should start with some radiobiology. So it's an old paper published in Red Journal in 1999 by Brenner and Hall on fractionation and protraction for radiotherapy of prostate carcinoma. And they found that the estimated alpha-beta ratio is 1.5 gray. And they showed at the time that external beam radiotherapy prostate cancer can be designed using larger dose per fraction, appropriately designed as a hyperfractionation schedule, would be expected to maintain current level of tumor control and late sequelae. So it can be a good option for prostate cancer management in terms of localized prostate cancer. And it is a paper published in 2016 in Lancet Oncology. We have the chief editor with us. So that the hyperfractionated radiotherapy is effective strategy for prostate cancer due to the higher sensitivity of larger fraction size, and it is convenience, and it can be used as a optimal utilization of the resources, as well as it is cost effective for a country like Bangladesh. So you can see the chart here that for conventional fractionation in the left, it will take around 8 weeks time, and for moderate hyperfractionation, that is 3 gray per fraction, it will take 4 weeks time. So it is 50% time utilization as well as the resource utilization. Key advantage already mentioned: for patient, less number of hospital visit, less cost to stay and transport for hospital, and less cost of treatment. And for hospital, less use of resources, so we can utilize the optimum resource, and we can treat more patients. So it is extremely relevant for a country like Bangladesh. So are there any enough clinical evidence for moderate hyperfractionation in prostate cancer? There are a few trials from 2010 to 2017. There are so many trials on moderate hyperfraction in prostate cancer. And here you can see these 6 important trials where they use, they compare the conventional radiation as well as the moderate hypofractionation. And here, in terms of response, you can see the biochemical disease-free survival, the 3-year and 5-year biochemical disease-free survival is almost similar. And the disease-free survival and progression-free survival, these are similar, and sometimes it is a bit better than a standard fractionation. And in terms of toxicity, it is generally similar side effects. It's providing similar side effects. But in Bangladesh perspective, at first, the main issue is it is told that the prostate cancer is not very common in our country. We are not getting so many patients, but we are getting some patients, and still now the practice is the conventional radiotherapy in case of prostate cancer in many centers of Bangladesh. So out of 47 patients in last 3 years, we treated 10 patients with moderate hypofractionation. That can be included in this study. So age distribution, it is in between 64 to 82 years, and the median age is 70s, late 70s. And if you want to see the demographic and clinical characteristics of the patients, most of the patients have a Gleason scores of 7, with fewer patients having Gleason scores of 8. And T2C is the most common clinical T stage as per HSCC guideline, followed by T2B. And this cohort is predominantly for a very high-risk patient and intermediate risk categories, with fewer in high-risk group. I will show in the next slide. So high Gleason scores, PSA more than 20, and advanced T stage are the primary contributors to the high-risk classification. And the PSA level, in the minimum PSA, I'm telling about the localized prostate cancer. So the minimum PSA was 4.2 and maximum was 54, and the mean PSA was 20 in my patients. And risk stratification already mentioned, very high risk group 4 patients, high risk 2 patients, and intermediate risk group another 4 patients. In terms of ADT, you can see here in the pie chart that it is not visualized properly actually. So most of the patients, like 70% with the current practice, that is received LHRH agonist, that is mostly goserelin, and some of the patients also received LHRH antagonists, that is degarelix, as well as relugolix and apalutamide. So the protocol of the treatment, moderate hypofractionation, I used 60 gray in 20 fraction, and the target volume, as because it is intermediate and high risk and very high risk group category, so I included the prostate, seminal, vesicle, and pelvic lymph nodes, and the technique was VMAT. So at first the PSA profile. So here the chart of my 10 patients PSA profile, the pre and initial, the post-treatment PSA profile. So patient with initial PSA level less than 10 nanogram per ml typically achieved significant post-treatment reduction, often dropping below 0.1 nanogram per ml. And those with higher initial PSA level, like 29, 40, 54, also showed notable decrease, though not always below 1 nanogram per ml immediately after the treatment. And sustained decreases were observed in most of the cases, with continued PSA decline over time. And cases with PSA level less than 0.01 nanogram to 0.1 nanogram per ml at 6 to 12 months follow-up indicate that it's a favorable outcome, treatment response. Now the bladder dose constraint, I experiment the D2cc and D50% volume. So D2cc, the value are tightly clustered around 62 to 63 gray, demonstrating excellent adherence to the dose constraint with a single outlier that is approximately 64.5 gray in my patients. And D50%, the range spans between 35 to 46. So the variation is much, and it is and which highlights the individualized treatment planning tailored to specific patient anatomy and clinical scenario. In case of rectum, the D2cc and D50%, D2cc demonstrate consistent value within the range, that is 57 to 60 gray, reflecting strong conformity to dose constraint with minimal variation, and D50% exhibits the widest variability, 32 to 48 gray, indicating flexibility in the treatment planning to accommodate individual patient anatomy, while highlighting the importance of careful optimization is needed to minimize the toxicity. So if we want to compare this toxicity, the dose constraint with the landmark evidence, we can see here for the bladder, the majority of the D2cc values aligned with the CHIP protocols recommended constraint, that is less than 65 gray, though a few plants such as 64.5 was observed in one patient. And regarding rectum, most D2cc values are within acceptable range. However, higher D50 values, particularly observed in 48.42, are approaching the upper threshold. It is the toxicity scale of my patient, the acute and late toxicities. And the toxicity profile, you can see here, the acute, that is less than 6 months, mild diarrhea, grade 0 to 1, occasional with mild rectal bleeding or proctitis, grade 1. And genitourinary, mild dysuria and urinary urgency or frequency, that is grade 0 to grade 1, was observed. And late toxicities, minimal late toxicities was found with no symptoms, and in terms of GI and in terms of GU, mild cases of urgency and incontinence, grade 1 was observed. So overall, the toxicities was low grade, consistent with hyperfractionation protocol in my patients. So with the correlation with the existing evidence, it is also telling that in case of like CHIP protocol or whatever the protocol available as evidence of moderate hyperfractionation, they will describe that the toxicity is lower. So we know the NCCN guideline is telling us to incorporate the moderate hypofractionation in very low to up to the high or very high localized prostate cancer, even in the presence of regional lymph nodal involvement also. So in Bangladesh perspective, We, the radiation oncologist, we are doing moderate hypofractionation for prostate cancer, and now we are looking for SBRT. So the take-home message is hypofractionated radiotherapy protocol such as 60 grain 20 fractions provide effective treatment with minimal toxicity. Advanced technique like VMAT and IMRT plays a key role in reducing rectal and genitourinary toxicities, leading to favorable long-term outcome, with most less toxicities limited to the grade 1 or less. While these findings support the safe implementation of hypofractionation in modern radiotherapy, additional data from larger studies is needed to validate the result. Multi-center collaboration is crucial to generating robust and comprehensive data. And this is my last slide. This is the picture of a study. It is taken by the organization of, by the initiation of Oncology Club, around 26 maybe, 26 oncologists, young oncologists received the graduation on structured course on prostate cancer under the leadership of Dr. Alessio G. Morganti from Bologna University. So they are the actually future of radiation oncology in Bangladesh, and we are hope that they will make more better plan of radiotherapy than us in near future. Thank you all.